clue which is mentioned in the question, with neutrophils inside the blister cavity. So I hope all of you know that vesiculobullous disorders are divided into intraepidermal blistering disorders and subepidermal blistering disorders. So the intraepidermal blistering disorder, I hope all of you know that they are pemphigus group of disorders, and subepidermal blistering disorders, the possible differential diagnosis could be bullous pemphigoid, it could be dermatitis herpetiformis, or it could be linear IgA bullous dermatosis. And among the given options, if you look at option D, rituximab, it is a monoclonal antibody which is used in pemphigus vulgaris. So we can rule this out. Why? Because pemphigus vulgaris is a intraepidermal blistering disorder. So the possible diseases are these, and what are the features which we can see is in bullous pemphigoid, yes, subepidermal blister can be seen, but the predominant cells in the bullous pemphigoid are eosinophils, whereas in the MCQ it is mentioned as neutrophils. So it is not bullous pemphigoid which about which we are discussing, and in dermatitis herpetiformis and in linear IgA bullous dermatosis, in both of them we can see subepidermal blistering disorder, and in both of them we are going to see neutrophilic infiltration, neutrophilic infiltration, neutrophilic infiltration. So you might be facing a difficulty here. You might think that it is difficult, but fortunately or whatever, the drug of choice for both these conditions is dapsone, so we can mark dapsone here. But otherwise, for additional information purpose, if you happen to do a immunofluorescence, in the immunofluorescence in dermatitis herpetiformis, what we can notice, so IgA deposition will be seen in both of them. Again, it is a common feature, but the methodology of the deposition of IgA is different. In dermatitis herpetiformis, the IgA is going to be deposited in a granular fashion along the papillary tips, along the dermal papillary tips. Whereas in the case of linear IgA bullous dermatosis, yes, if you have guessed, it is going to be linear fashion along the basement membrane zone. So in linear IgA bullous dermatosis, IgA deposition will happen linearly along the basement membrane zone. So this is about this MCQ. Okay, let us move on to the next question. So these are all very important, but yes, we are just quickly seeing the questions and answers, so we are skipping all this. So this is the next question. A patient came with grouped vesicles periorally. So periorally, the patient is having some grouped vesicles. What will be the Zank smear finding? So this is MCQ, and if you happen, these are the lips. Okay, for your information, these are the lips, and periorally you are able to see grouped vesicles over erythematous base. Then our diagnosis is going to be herpes labialis, which is produced due to herpes simplex virus type 1. So in these cases, Zank smear is always performed, and you must remember that in Zank cells will be seen and also multinucleated JN cells, both of them will be seen. So you might be wondering what are these cells. So I will describe in brief about both of them. So Zank cells are basically nothing but the acantholytic cells, acantholytic cells, which are nothing but the keratinocytes which have lost their intercellular connections. So in the case of the herpes simplex viral infection, there is going to be what is called as secondary acantholysis, which can be seen, secondary acantholysis. So I hope all of you know that primary acantholysis is a feature characteristic for pemphigus group of disorders, whereas in the viral infections, yes, we can see secondary acantholysis. So acantholytic cells or Zank cells can be seen, and this is a viral infection, and in this, yes, we can see the multinucleated giant cells. So basically what are these? These are nothing but the keratinocytes which are going to become a group. They are going to group together, and since these keratinocytes are having nuclei individually, but whenever they are going to combine with each other, then we are going to have a cell which is going to have multiple nuclei, and these are called as multinucleated giant cells. And yes, both of these are seen associated with herpes infections. So here you can see these are the Zank cells. I hope you are able to see. and I hope you are able to see these are the multinucleated giant cells. So this is the next question. So which of the following is correct among the following statements regarding the disease shown in the image? So you need to identify the correct statement about this condition, and in the condition in the image what you are able to see, there is some pearly white papule which is having a central umbilication, and not only that, along with that, if you observe carefully, the lesions are present in a linear fashion. So what does this mean? This means that it is a Koebner's phenomenon. Koebner's phenomenon is positive, Koebner's phenomenon positive, and by both these clinical features we can diagnose this as a case of molluscum contagiosum, molluscum contagiosum, molluscum contagiosum. Okay. So among the given options, yes, central umbilication is seen. This is a right statement. Zhang smear has no role in the diagnosis. This is a wrong statement. Why? Because in Zhang smear of molluscum contagiosum, we can see HP bodies. HP bodies, I hope all of you know the full form of this. Please type your answer, that is what is the full form of HP bodies, in the comment section below. Yes, Zhang smear can be used in the diagnosis of molluscum contagiosum, but since it is mentioned as it has no role in the diagnosis, this is a wrong statement. And no, this is not a bacterial infection, so no, Gram-negative cannot seen. And Pund cells. So we will see what are these Greenblatt and Pund cells which are seen in Donovanosis. Okay. So these are not seen in the case of molluscum contagiosum. So as you can see, Greenblatt and Pund cells, these are basically mononuclear cells. The nucleus of the cell is eccentrically placed, it is pushed towards one side, and these are basically, there are less than 20 intracytoplasmic vacuoles containing Donovan bodies in either young non-capsulated or mature capsulated forms. So these are basically associated with Donovanosis, which is also called as granuloma inguinal. So you should know the other names of the sexually transmitted diseases. It is very important. Okay. So if you see here, Donovanosis, it is also called as granuloma inguinal. Very important to know this. And apart from this, there is one STD which is having a name called as lymphogranuloma venereum. So can you tell me what is a causative organism for lymphogranuloma venereum? This is very silly looking question, but it can be asked as MCQ. So that is the reason why I am asking this question to all of you. Please type your answer in the comment section. What is the causative organism of lymphogranuloma venereum? So this is about molluscum contagiosum. And now if you observe this lesion carefully, identify the lesion, and based upon the morphology, what is this described as? So one second. Yeah. So if you observe the lesion carefully, the lesion is coin to oval shaped, and what is that peculiar thing which you are able to observe is that at the periphery the lesion is having a rim of erythema is present, whereas in the center, if you observe carefully, the center of the lesion is clear. The central clearing is present, and there is some peripheral difference of the texture, or the lesion is either slightly elevated or there is some change in the color. So whenever you get to see this kind of a lesion, we call these lesions as annular lesions. We call these lesions as annular lesions, and there is a very easy trick for all of you to remember annular lesions and discoid lesions. So just remember idli vada. Idli vada are very famous breakfast in the South India. So if you observe this idli, this is called as idli. This is having a solid filled circle kind of appearance clinically, and these lesions, when the patients are having, they are called as discoid lesions, or the other name for discoid is nummular. Okay, whereas if you see on the right hand side, this is another breakfast item which is called vada, and if you observe carefully, there is a at the periphery, this is open circle with center different central skin here. You can simply take the analogy of this central area, which is deficient, which is absent, and it is different, quite different from the periphery of this vada. So likewise, in a annular lesion, the lesions are going to be open circles, open circle. So you can see this is an open circle with different center and a different periphery. So both of these are different in the case of annular lesions, whereas in the discoid lesions, the entire lesion is going to be a complete filled circle. So if you observe some more lesions, probably you will understand what is the difference. So if you observe carefully, these are annular lesions. Why? Because at the periphery the lesion is having different characteristic, whereas at the center there is clearing, or at the center the lesion is different from that which you are able to see in the periphery. So this is appearing like a vada, and here the multiple annular lesions, when they coalesce together, they are going to form these kind of arcuate lesions. These are called as arcuate, or these are also called as polycyclic lesions. Polycyclic or arcuate lesions, arcuate or polycyclic lesions. And contrast the previous pictures with this one. So if you observe, this is very shiny, very oozy, and it is erythematous. So this is basically a case of eczema, and since it is coin shaped or discoid type shaped lesion, this is also called as nummular eczema. Nummular eczema. And if you take the analogy of the idli, this lesion is not having any difference whatsoever in the periphery and in the center. It is entirely looking like a fixed filled circle. So this is a discoid lesion. I hope now it is very clear for all of you, the difference between annular lesions and the discoid or coin shaped lesions. So this is a future MCQ. Causes of painful ulcers over the tip of the glans penis. So you need to identify what are the possible DDs if a patient has a tip of the penis presenting with painful ulcers. So yes, both herpes simplex viral infection as well as Haemophilus ducreyi, which can cause chancroid, both of them are going to present with painful genital ulcers. And this is the next question back to back about chancroid, which is caused by Haemophilus ducreyi. True statements are all of the following except, okay, yes, in histopathology we can see a peculiar appearance called a school of fish or railroad track appearance. And yes, these lesions of chancroid are also going to bleed on touch. But apart from this, there is one sexually transmitted disease which is beefy red, which is going to present with single painless ulcer, which is very beefy red for appearance, and it will very easily bleed on touch. So if you know the answer for the description which I have given, please type your answer in the comment section below. But other than that STD, even this chancroid, which is caused by Haemophilus ducreyi, is also going to bleed very easily on touch. And yes, in the previous question itself we have seen chancroidal ulcers are very painful ulcers. And we are left out with groove sign. Yes, that is the answer. That is the false statement among the given options. And groove sign, it is present in lymphogranuloma venereum. And one more question, an answer which I am going to tell: pseudo bubo and pseudo groove sign. Both of these are characteristic features of donovanosis. So this is also one important point which you must have an idea about. So difference between syphilis and chancroid I have given in a detailed fashion in the previous year questions of the AIM, so you can check that out. So yeah, so as you can see here, the chancroid, the causative agent is Haemophilus ducreyi, and if you observe this gram stain carefully, you are able to notice that these gram-negative Coccobacilli Haemophilus ducreyi are arranged in a parallel rows, one after the other, just like school of fish. So this is a classical description which is seen in the case of Haemophilus ducreyi. So this was discussed in microbiology, so we are not going into the details of this. Yes, investigation of the choice for allergic contact dermatitis, so this we have discussed in a very great detail in the previous year questions of AIIMS. So I will leave the links for all the AIIMS previous year questions in the description and also in the iCard. You can check them and you can watch them out. Here the answer is patch test, and I hope all of you do remember that the two times at which the readings are taken are, one is at 48 hours and the other one, the best reading which can be taken, is at 96 hours, which are nothing but 2 and 4 days respectively. So the process and all we have discussed, and there is a possible future question. True test is a variant of, yes, this is a variant of the patch test. It is actually a test which patients themselves can buy from a pharmacy and apply over their body, and they can themselves identify what are the allergens. Okay, so these are available commercially, but not so much available in India, but available in other countries already. So TRUE stands for thin layered rapid epicutaneous patch test, rapid use epicutaneous patch test. Thin layered rapid use epicutaneous patches. This could be a possible future MCQ, so please make a note of this. As you all know, AIIMS always try to level up the upcoming examination questions. And this is the image, clinical image, and you need to identify this condition. And yes, very good if you have marked the answer as mycetoma. So this is a classical picture of mycetoma, and if you remember yesterday we have discussed sporotrichosis in a great detail. So now let us quickly see what are the features of these deep fungal infection. So basically all of these are subcutaneous mycosis. So usually fungi are going to involve only the superficial parts of the skin, but in these cases of sporotrichosis, chromoblastomycosis and mycetoma, there is going to be a history of trauma. This is very very important. A history of trauma will be there, because of which the thorns or soil which will harbor these fungal spores, they are going to directly inoculated into the deeper structures of the skin and manifest in varied varying types depending upon what are the fungus which have been inoculated into the patient's skin. So in the case of mycetoma, there are two possibilities that it could be eumycetoma or it could be actinomycetoma. So what is the difference? I have made a very very detailed video on a mycetoma topic. I will leave the link in the iCard, so you can check that and you can know what are the features of mycetoma. And I have also discussed about one very important regimen and mnemonic to remember the components of this regimen which are used in the actinomycetoma, which is caused due to bacteria. And because it is bacterial, it is not antifungal which is used in the treatment of this actinomycetoma. But in eumycetoma, I hope you all know that itraconazole is used for the treatment of the patients. So you can remember the features of mycetoma with the help of GST. So what does GST mean? GST is actually a movie which was directed by Ram Gopal Verma. But here our mnemonic for mycetoma is GST. And what does G stand for? G stands for there will be granules which will be oozing out of the lesion. So that is the G. And what is swelling? Swelling is sinuses. So the granules, which are also called as the grains, which are basically nothing but the colonies of these microorganisms which will be thrown out of the skin through these sinuses. And what is tumescence? Finally, what you are able to see, you are able to see a swelling. So a very posh word which is used for swelling is tumescence. So GST, these are the features of mycetoma. And sporotrichosis, and this is future MCQ. So let us, yeah, and this is the question, and this is actually a hair which is seen under a microscope, and this picture what you are able to see is classically described as tiger tail. tiger tail appearance on polarized microscopy, and this is very classical feature for trichothiodystrophy. So what is this trichothiodystrophy? It is also called as PIBIDS syndrome, where P stands for photosensitivity, I stands for ichthyosis, B stands for brittle hair. So hair abnormality will be there. So we'll see in detail what are those hair abnormalities. I here stands for intellectual impairment. D stands for decreased fertility or hypogonadism, and S stands for short stature. And as I've already told you, B is brittle hair. And what are the hair changes which we can see? So if we observe the hair under polarized light microscopy, we can see this tiger tail appearance. Why is it called tiger tail? If you observe, tiger tail is going to be having stripes of yellow and black in alternating fashion. So likewise, you are able to see the hair under polarized microscopy showing this alternating bands of yellow and black. So this is called as tiger tail abnormality. And yes, this is classically seen in trichothiod dystrophy. And not only that, in these patients of trichothiod dystrophy, we can also see trichorexis nodosa, which is also one important feature. So now let us see, this was a previous JIPMER question also. So let us clarify what are these terms: trichorexis nodosa, invaginata. Trichorexis invaginata, it is also called as bamboo hair, and it is classical of Netherton syndrome. This was a previous question, so please do listen to this very carefully. So in this, the patient's hair, if we observe carefully, we can notice that the proximal part of the hair shaft, so this is the proximal part of the hair shaft, it will form a socket, whereas a distal part of the hair shaft is going to form the ball. It is going to form the ball. So a ball and socket kind of hair shaft abnormality can be seen, because of which this will appear as if we are noticing a node, as if we are observing a node. So this is given a special name. It is called as, because there is invagination of the hair shaft, it is called trichorexis invaginata. Okay, and apart from this, there are some other features also. As you can see, in the patients of Netherton syndrome, even trichorexis nodosa can be seen. What is this trichorexis nodosa? So as you can see in this picture, so this is a hair, and you are able to notice that the hair is having this paint brush. If two paint brushes are opposed, how does it appear? So likewise, the hair shaft is damaged, it is broken down, and we can notice this hair, paintbrush like appearance in the hair shaft. It is called as trichorexis nodosa. And apart from this, some other features in the skin which can be seen are: one is ichthyosis linearis circumflexa. So just remember, ichthyotic changes are seen, and along with that, a history of atopy can also be there in these patients of Netherton syndrome. It is basically due to SPINK5 gene mutations. And this is the last question. A patient of psoriasis came for the treatment, and on clinical examination, it was observed that 50% of the body surface area is involved with the lesions. So which drug is not used in the management of this patient? So this was discussed in a great detail in the previous year questions, in which pustular psoriasis was asked. And if you remember, we have seen beautiful mnemonic PLABS as the drugs which can trigger the psoriasis: the painkillers, lithium, the antihypertensives, beta blockers, and S for steroid withdrawal. So these are all the medications which can produce psoriasis. And here, if you observe in the options, steroids is mentioned. Please remember, topical steroids are okay in the psoriasis patients, but oral steroids are definitely not to be used in the patients of psoriasis. Why? Because though it is a inflammatory condition, and after giving the steroids, which are anti-inflammatory medications, but the withdrawal, during the withdrawal, if the drug is if not tapered, and if it is withdrawn abruptly, then the patients are going to land up into a very severe complication, which is, one is erythrodermic psoriasis and the other one is pustular psoriasis, which is also called as von Zumbusch disease. So because of these reasons, steroids, oral steroids are not to be used in the patients of psoriasis. I hope this is very clear. So these medications are also very important which can cause psoriasis. So painkillers, that is NSAIDs. L stands for lithium. A stands for anti-malarials. B stands for beta blockers, which are the antihypertensives. S stands for steroids. S stands for steroids. So please make a note of all these. And apart from this, what are the treatment options for psoriasis? About this, I have made a very beautiful flashcard. You can check that out. I will leave that link in the iCard above, and you can watch that video as well. So I hope you all have enjoyed this video. Please do hit that like button, and the target for the total likes for this video is I expect at least